Good day, everyone. Thanks for joining us on Northwest Access TV. I'm Richard Cowperthwait. Happy to have on board today Peter Wright, the CEO of the Northwestern Medical Center. Peter, nice to meet you. Thanks for your time.
My pleasure. Thank you for having me.
Anyway, great to see you. I've heard you on radio before. Give us a little background on yourself.
Sure. I came to Vermont in 1990 to go to school at Linden State College.
Weather's a passion of mine. In retrospect, I think I fared pretty well college-wise, but
it's one of the best programs in the country.
Jim Cantori, probably the most famous weather guy in the country. There's a lot of good folks out of Linden.
For sure. It was a great place to go to school,
Really?
small, intimate, kind of why I stay in the circles that I do. It's part of what makes Vermont special, and I never left. I came up here because I loved having four seasons, and I loved small towns, and really knowing the folks that you work with, and it just resonated with me my whole career. I worked in a couple of different fields, didn't really know what I wanted to be when I grew up. So I worked in ski resort management.
Imagine that.
Yeah, I'm still waiting to grow up. But, I worked in ski resort management. I was a law enforcement officer for 6.5 years. I sold radio ads, did a variety of different things before a good friend of mine who I went to college with kind of dragged me into healthcare.
Really? Interesting.
It just tapped something into me. I remember I was in that first job at Copley Hospital in Morrisville for about 6 months, and it was a nice, cool, crisp day like today, and was driving to work and was really excited to get to work. And I remember at that very moment that this is what I was going to do for the rest of my life. And,
really?
And every day for the last almost 25 years now, I wake up and I'm really excited to get to work. I love not only what we do, but who we get to do it with.
Boy, that's great. Oh, that everybody had that situation. I've been pretty lucky on that front. Journalism around here has treated me pretty well. And speaking of which, I mentioned off air, boy, I've been reporting in one fashion or another around here, not so much these days, but for about half a century. But certainly one of my biggest stories as the radio news guy when St. Albans had, I think, a decent radio station was just the transformation of the Northwestern Medical Center with the battle between where to locate the consolidated hospital. In fact, I think I can flash back to Dr. Fred Holmes coming to me probably circa late 70s, maybe early 80s, saying, "Hey, Rich, we're having a news conference. We have some big hospital news." And the battle over the radio airways, over the partisans of St. Albans Hospital and curbs. I mean, it was a battle for years, some of which I'm sure you're obviously have heard about.
He's a pediatrician, right?
Yeah, and a very, very well-regarded guy.
Just to prove what a wonderful and small world this is, his son, Chip, is somebody I work with today.
Oh, really?
Chip works for a national healthcare organization that we have a strategic partnership with, and Chip talks with great affection about his affinity for Northwest Medical Center and his dad and his family and growing up in this area.
Yeah. Anyway, that was a big story and a continuing story. Boy, healthcare is not too much in the news these days. I mean, it's just.
We sure would like not to be, that's for sure.
Boy.
It's complicated, Healthcare takes up 18% and growing part of GDP, and that means it hits everybody's
18%?
Budget, and we heard last year, the connection to property taxes. And what's unfortunate is the right message isn't getting out there. The full truth isn't getting out there.
And feel free to tell us about the full truth.
Sure. Healthcare costs are going up, probably for most, but it's not because of rate. I mean, costs go up either because of rate or volume.
Yeah.
And what's happening and what we're seeing across the country is utilization is going up. Whether it's delayed care that people did not get during the pandemic, or just people are sicker. We're seeing it. There's statistics and data that show that the level of what we call the acuity or how sick somebody is has increased quite a bit over the last year or two.
Is that right? I'm used to seeing stats on obesity, but not so much some of the
that's going up too, unfortunately. Yeah. I mean, I think our country and our state and our community, while there are pockets of people, diving into fitness and doing better, there are still plenty of people getting sick. Our emergency department is full. Our urgent care is full.
Yeah.
Primary care offices are full. I mean,
Yeah.
it's just really hard. And
in fact, last night, just watching Montreal News, which I usually do before I go to bed, CTV News at about midnight last night, they had the football game on. But just some of the Montreal hospitals, Jewish General mentioned emergency room was like over 200%, attendance, what it should be. Just ER is just...
Yeah.
And again, Northwestern Medical Center, same situation as the ER is just way busier than you'd like it to be.
We have one of the busiest emergency rooms in the state. It's certainly busier than we would like, for sure.
Yeah.
I mean, when our emergency department's busy, it means something bad's going on.
Yeah.
As a result, many years ago, they developed urgent care, which is a way to get folks, not to use the emergency department or reserve the emergency department for those who are really, really sick. And we always encourage folks to go to their primary care provider first. But there's plenty of patients in our area that are they're sick. And this time of year, you add on top of that injuries, whether it's motor vehicle accidents or slips, trips, and falls, more cardiac issues because shoveling snow, although that doesn't seem to be too big of an issue at this point this year.
Not so far this winter, yeah. Interesting. The norovirus, that's getting a lot of attention these days. I've got a good friend who's cruising now on the Queen Mary 2, and she was a little freaked because I guess they had an issue when they got back into New York City from the Caribbean and did a deep clean, but... Anyway, but norovirus, is that
Yeah, absolutely. We see it all the time, different types of flu. We're still dealing with coronavirus, although it's much, much less these days. Yeah. It's part of being a global economy. It's part of people traveling internationally. Access to travel is so easy.
Yeah.
Young kids these days are going all over the world, and I think I was
my kid's a good
30 or
example.
almost 40 by the time I went to out of the country, excluding Canada. So I think as we become a global economy, as we travel more, the transmission of viruses or diseases like that is just so much more rapid, as we saw with coronavirus.
Wow. How long, I should back up a little, how long have you been at Northwestern Medical Center, Peter?
Coming up on it'll be 2 years at the end of this month.
2 years in.
Yeah.
So at least you missed the heart of the COVID situation pretty much?
I did. We had a little bit in the very beginning where we were still wearing masks and some flare-ups, if you will, but I spent most of COVID in Western Maine.
Oh, is that right, Western Maine?
Yeah, I ran 2 small hospitals over there, part of the Central Maine Health System, and it was hard.
So the situation over there, I guess everywhere was pretty tough. I mean, think of obviously a pretty rural area, but... Yeah,
definitely. It's the one time that being in a rural area was a health advantage, right? Because we don't interact with as many people.
Right.
But access to care changed, and the need for healthcare providers was probably the greatest it's been in my lifetime, for sure.
Wow. So 2 years at Northwestern Medical Center. The health of, again, I realize any of these topics you could spend so long on. I guess maybe go right back to the consultant. What Oliver Wyman, the consultant that Green Mountain Care Board hired. And I've got a camp in the Northeast Kingdom, go through Newport and get the Chronicle, a very good weekly paper. And of course, North Country Hospital in Newport was kind of on the front lines, I guess, with apparently the consultant suggesting that maybe just keeping a full-fledged hospital wasn't the best way to go. And folks in Newport have nothing I have to tell you, pretty much freaking out about that.
Sure. I would be too. I used to live in the Northeast Kingdom, spent a lot of time up there.
Really?
I think not having a hospital in Newport would be treacherous. I mean, it would absolutely hurt the people of the community.
For sure.
Just having to travel too far, whether they're coming over the mountain to St. Albans or having to go to St. Johnsbury. It's just, we talk about the golden hour in an emergency, right?
Oh, yeah, golden hour.
And that's an hour from, if you have some kind of traumatic health issue, EMS will talk about that golden hour from the time of that event to the time you're getting care. And lots of times there's more than an hour of travel, depending upon where you're coming from.
Wow.
I understand the underlying concepts of where Dr. Harmony and the Oliver Wyman report are coming from.
Yeah.
I unfortunately think they went into the exercise with a predetermined outcome.
Really? Interesting.
And unfortunately, it falls short in a couple of areas. First, it doesn't embrace Vermont values. The people of Vermont have chosen to live a certain way, and industrializing healthcare organizations isn't the remedy. Number two, it doesn't take into account the rural landscape. It doesn't take into account that Vermont has an unusually large number of small communities and small hospitals. If we were all the size of UVM with a population to match, there'd probably be an opportunity to create centers of excellence. But you need basic levels of healthcare in certain, in every community, And, just deciding that certain random people, whether you're in Randolph, which by the way, has a college.
Which is Gifford.
Gifford Medical Center. I mean, it has a college, and there's farming, and a lot of things that drive the utilization of healthcare. It's just not a good idea. And as we learned, there were some pretty significant data integrity issues, and so drawing conclusions from a report where the data isn't sound is not a good idea.
Did it make sense for Green Mountain Care Board to go to hire a consultant? Was the process that makes sense what they were doing to you? And I guess you could probably talk about Green Mountain Care Board for quite a while.
Yeah, I could, for sure. I think they skipped a couple of steps.
Really?
I think and again, I've only been here for 2 years, so I've watched a lot of this history from the outside, not the inside. I want to be respectful to that, but it doesn't appear that there's been any attempt to bring all of the parties together to figure out how we can move forward together. I mean, one of the great attributes of being in Vermont is collaboration. Is the grit of getting things done by coming together, and I don't see that we've been given an opportunity to do that.
Interesting.
There was a lot of people, and the former head of the UVM Health Network used to be a big proponent of this thing. All these small hospitals should stop doing things and everything should go to the university. And I think Dr. Epen and Dr. Leffler would say today that's exactly what we shouldn't be doing. Right? I mean, care should be left to the smallest environment that it can be and reserve the very precious space and resources of the university for the very sickest of the population. And it doesn't seem like too many people understand that. I know that everybody in the healthcare field in the state of Vermont agree UVM is a precious resource. There isn't enough space, there isn't enough capacity, and so we should be reserving that for people who really need to be there. And that means, figuring out how to strengthen our community hospitals, not weaken them. And the fundamentals of that are figuring out how to grow Vermont.
Was one of the recommendations, or Northwestern Medical Center, the dialysis unit? Sounds like that was a big thing. Did that come out of the Wyman report, or was that a separate? So
the Oliver Wyman report recommended as a suggestion that Northwest Medical Center be a specialist in cancer surgery, which is fine.
Really?
It's things that those are types of surgeries that we do today. One of the things that concerned me is that they also recommended that we do radiation oncology. And I would say, as a cancer survivor, as much as I love my hospital and I get my care at my hospital, radiation oncology is incredibly complex and belongs at an advanced medical center like UVM.
And that's something Northwestern is not doing now.
We're not doing it now. It would be expensive to buy a linear accelerator.
But they recommended
we don't have the staff.
They recommended that you start.
Yeah, and we don't even know why. And so that would mean most of the people in the state would have to drive right by UVM to come to us. And it just didn't make any sense.
So the recommendation was NMC doing that and not UVM?
Yeah. Really? I don't understand. Those are the part of the things I don't understand how that conclusion. Again, that was a suggestion, a recommendation, not a kind of a steadfast order. The issue that you mentioned about dialysis,
which certainly got some attention, obviously.
Yeah, the Green Mountain Care Board, in its deliberations, decided that the budget that UVM submitted was too much. So they basically rejected two aspects. One, they rejected their rate commercial rate insurance request. I don't remember exactly what they had submitted, but nobody got more than 3.4%, which is a problem. Then they implemented something called enforcement, and that's part of the second thing that they approve is what your net patient revenue is allowed to be. So they did not approve UVM's net patient revenue proposal and went back to previous years, I think it was 2023, and said, well, you exceeded your net patient revenue allowance in 2023, so they made them pay it back. Or they're making them pay it back, over $80 million. By the way,
really?
It took UVM, had to spend $102 million in order to generate $80 million worth of net patient revenue. Wow. And they did it because they were expanding access as they were instructed to do in the previous years. So it just doesn't seem like the Green Mountain Care Board is either understands when they issue an order what impact that will have, and or they don't understand. I don't drive volume. I mean, people come to us when they need care. Yeah. Last year, when I did my first budget presentation, they said at Northwest Medical Center, your waits are too long. You need to improve access. Really? Your waits are too long.
Waits are too long.
So we did what they asked. We agreed with them, by the way, and we had been recruiting. We recruited more members of the medical staff to join.
And waits being just for people trying to get an appointment?
Yeah, how long it takes to get to see a provider, a doctor or an advanced practice provider. Weeks, sometimes months. Too long.
I hear that about UVM all the time.
Sure.
I guess not so much about
And so what do you do is you recruit more people to see more patients because the need is growing, as we talked about earlier. Yeah. Every time we see a one extra patient, it generates more revenue. Yeah. So the idea that they would, penalize us for, or UVM for more revenue when they were doing what they were asked, which is to expand access, just seems, misinformed and kind of backwards. There's a need for healthcare. Expanding access is the right thing to do. Limiting access means people are going to get hurt. Yeah. So expanding access is the right thing to do, and that's going to generate more revenue for a hospital when they expand access.
Does Maine have some other states, you're familiar obviously with some other states, does Maine have a similar situation with a Green Mountain Care Board, or is Vermont?
No, both Maine and New Hampshire do not have any regulatory body that acts in that way. You're allowed to
so hospitals just
you set your budget and you negotiate with the commercial insurance companies based on business negotiations like anybody would. And kind of the market is the market.
Interesting. So it sounds like you're not real impressed that Vermont has this regulatory. And again, can you maybe talk about Green Mountain Care Board a bit? I mean, these folks have they've got the final say. I mean, they can reject, accept budgets, and make make Northwestern Medical Center spend less. I mean, they have the final say here.
Governor Shumlin, former Governor Shumlin, created the Green Mountain Care Board, and the first year they were in effect was 2011, and their goal was to, make commercial insurance more affordable.
Of course, Governor Shumlin, who had the hope for a single payer, which he conceded defeat on, obviously, during his administration.
Yes.
Was that kind of in the wake of conceding defeat on that he went to?
I don't remember at the time. It was too long ago for me to recall.
Yeah.
But the concept of reducing the cost of healthcare is an important one.
Sure.
One that all of my peers and colleagues sign on to. Sure. We want to do everything we can to make healthcare more affordable, because when it's more affordable, people will continue to access it. And when they access healthcare, they stay healthier. Yeah. And that's what we want. We want a healthier Vermont. Sure. So the way that works, and the way the laws and the regulation are written is that the mechanisms that the Green Mountain Care Board control are what rate increase they can charge commercial insurance, and what our revenue is allowed to grow from year to year. The rate increase, there is an increasingly smaller number of people in Vermont who are using commercial insurance. Hence the reason that the real answer is grow the number of people in Vermont.
Yeah.
The Vermont Futures Project is run by a gentleman named Kevin Chu, and I listened to a presentation he's done a couple of times that basically says just to meet the basic demands of Vermont in 2035, we need conveniently 802,000 people.
I've seen those stories. In fact, it was funny. One story that I saw, the reporter messed up a little bit. Nothing I can relate to. I'm kidding, but the reference in the story I saw was Vermont needs not getting up to 800,000 people or so, but an additional 800,000. I'm saying, oh no. Anyway, but
I don't think anybody wants to see Vermont, double or triple in size.
Population now being about 640,000 or so. So that's a huge, of course.
And there's only 200,000 some that are working on commercial insurance, and I get that's just not enough. I mean, insurance works by having as many people as possible of all ages to leverage risk across a broad spectrum. We know that younger adults, they use less health care. So they end up paying a premium that subsidizes and supports, folks my age, older in age, but not yet on Medicare. And that's what makes it work. We need more people. Vermont needs to grow its way out of all its economic problems, not just healthcare, property tax, the pressures that are being put on schools. I mean, just every corner of our society and economy in Vermont just needs to grow.
Yeah, no, it sounds like it's just the issues. I interview legislators and candidates, and boy, they've got a lot to deal with. It just sounds like the word crisis isn't a crazy word to use for some of this.
So, getting back to your question about the Green Mountain Care Board, we don't see it in other states. So
really?
There is in some, but it's very infrequent. But I support the idea of regulatory oversight.
Yeah.
I think it's important. I think that time has proven that overall oversight of some kind is good to make sure that people aren't abused in any industry. How much and what way, I think we could have a lot to talk about. I think the major problem with the Green Mountain Care Board is healthcare is been deemed by a lot of third-party experts as the most sophisticated and complicated industry in the world. It's incredibly...
Sounds like a fair description.
It's incredibly complicated to understand. It is not like regular business where you push one lever and you know you're going to have a desired effect.
Well, what's tougher, that or education funding, another issue that nobody,
Well, education funding is certainly difficult. I think, having lived in Vermont on and off for a number of years, having had my children go through the school system, and participated on a volunteer committee to look at, consolidation in a particular school district, I think we're avoiding the inevitable. Unlike healthcare, education can move a little bit, not a lot, right? I don't want to send kids to Rutland or even to Montpelier or even to Burlington for that matter. But having grown up in a school system that was regionalized, we had to travel a little bit. And it's about numbers, right? Just like healthcare, there's a basic infrastructure in any school that they need to meet regulatory guidelines. And I think that we need, classes that are a little bit bigger. And it's hard to get staff, right? I mean, and again, I don't want to oversimplify something that's incredibly complicated. But I do think that my colleagues in the education field, particularly, K through 12, are headed down a road very similar to where hospitals are today.
Interesting.
If our communities don't grow the way we would hope. And quite frankly, our communities can't grow as fast as they need to catch up in the short run.
Well, it sounds like there's just a lot of very, very difficult issues out there.
It's really complicated. We talk about affordability, and a lot of people say
a huge issue with Republicans.
Yeah.
Faring much better than expected at the last election because of that.
And I think we're going to hear a lot about it in the legislature this year.
Sure.
And they tend to kind of point at healthcare, and I think there's a fair criticism as part of that.
Yeah.
There's a lot of things that we're not doing, and there's a lot of things that we're doing that are wrong in the state that, from a policy standpoint, can be changed to make healthcare a lot more affordable. But what is affordable?
Yeah.
Try to buy a new car.
Yeah.
Try to go to the grocery store, buy a cell phone.
Buy a house. Good luck buying a house.
My children who both do well. They're above the state median in terms of income, and they're young, right? They're in their 20s. They can't barely afford to buy a house.
Yeah.
Just going out for something to eat. It used to be, really reasonable to go out and have a nice meal with friends, and now you really have to think about it.
Yeah.
What are we going to spend money on? And I don't think we can go out. Well, we go out. I know I go out a lot less, and I'm sure that I can afford more than others.
Yeah, I'm sure you have plenty of company with that. Boy, in your job, I get discouraged just doing a bit of reporting still in my old age, but like I said, these issues just seem almost overwhelming to me. But you're in a key job here, but you hopefully don't get overwhelmed. Is there always some light at the end of the tunnel for you? But it just seems like I just get easy to get very discouraged about the issues we're talking about.
Sure. My job is constantly making decisions, choosing between one project or one problem to solve over another. We just don't have enough resources to attack it all.
Yeah.
But I love what I do, as I said earlier, because I love who I do it with. I walk into a building every day full of 700-800 people who want to help other people. We have the best mission in the world, right? Folks come in our doors and they trust. They trust us during their best moments, like when they're having a baby, or some of the darkest moments of their life. And that's a real treasure, and it's never lost on me, what a privilege that is. So we work through some really hard issues every single day of just trying to take care of our community. But it's a privilege. It's a privilege to work with the team and the hard. I often quote the movie, Tom Hanks in the movie A League of Their Own, where he says to Gina Davis, the hard is what makes it great. Right? If it were easy, somebody else would do it.
Yeah. Staff at NMC, I guess you touched on it, 700 to 800 or so?
When you mix part-timers and full-timers, and then there are people who work in our building who aren't our employees. They work for other organizations. So I kind of say the NMC family, which is some people who have an NMC logo on their paycheck and some people who have a different logo. But the folks who come in our building is somewhere between, it's about 750.
So talk about obviously a huge, the biggest employer outside of the school system in Franklin County, maybe?
One of the biggest employers for sure. And yet, by all other measures, we're considered a small hospital.
Yeah, interesting. Market share for the hospital, obviously, most folks in Franklin County will go to Northwestern Medical Center, especially Northern Grand Isle County. Do you grab some Milton folks? Do you grab some out of Chittenden County? Or
a little bit. We have a few people from Milton, I would say. Anybody, and that's probably, without knowing exactly for sure, probably a migration of work. We know that when you go to a different community for work, your healthcare tends to follow. We capture, in rough terms, about 56% of the market share for Franklin and Grand Isle County.
Is that right?
Yep, which is pretty low.
You'd like to see that a lot higher?
Oh, yeah. I think I would love to see it at 70 or 75%.
Really?
For sure. Our job is to take care of Franklin and Grand Isle County. That's what we're here to do. That's what we want to do. We know that of the remaining 44%, 42% engage in the UVM Health Network. And all you have to do is sit near the any interstate exit in Franklin County at 6 or 7 o'clock in the morning and understand why. There's just so many people leave the county for work. Some people kind of have the halo brand glow of bigger is better. And there are some things that absolutely should be done at the university and not. And so we think that's about 20% plus or minus. 25%, say. So I think there's a room for opportunity for us. And we've been seizing on that in the last year and a half with expanded access and just making it easier to get in and easier to do business with us.
Has that percentage changed at all? You've just been here a couple of years, but have you been able to kick that up in a couple of years? Or
Unfortunately, the data trails about 18 months.
No, is that right?
We don't have real-time market share data.
Yeah.
So I can tell you that our volumes are going up. Some of that is because folks are sicker. Some of it is because we're easier to get into. There's less of a line.
Right.
And you hear anecdotal stories around, I went here, I went there, and now I'm choosing to go to NMC because of the way we're cared for, or it's easier to get into.
Your relationship with Notch has had a huge impact, I would say, in Franklin County. One of my best friends is on the board. My doctor, who unfortunately I'm about to lose, is a Notch doctor. But can you talk about the relationship between, and boy, Notch has expanded big time. It's a big player around here.
Absolutely. I think we have two very large we'll say private practices. When I say private, not employed by Northwestern Medical Center for primary care.
Yeah.
And then we have a handful of smaller, sometimes one or two or three primary care providers. I think that's great. I'm a strong supporter of that because all they do is primary care. And when all you do is primary care, you can get really good at it.
So that is all, that is all they do?
Yes,
Okay.
And so the Notch and Primary Care Health Partners are the two big places, and they do primary care and primary care exclusively. Right. The Notch, being a federally qualified health center, is able to leverage cost-based reimbursement for Medicare and Medicaid visits. Right. So what would normally be the lowest paying providers if they were employed by us is now probably the highest paying providers for them, and they're able to leverage, 340B and a lot of other federal programs to bring additional services to the community that are invaluable. And I think that the general health of the community is benefited by having access to those, programs. I mean, in addition to having a pharmacy, which is great, right on our campus, that's run by Notch, they run a grocery store up in Richard.
That's pretty incredible. I think they're, and like I said, one of my best friends is on the board. I think they're actually, if not making money, they don't lose money. But that's pretty impressive what they've done.
I think their biggest challenge is just recruiting and retaining their medical staff. Some are getting to the point, like as in with your physician, where they're ready to retire, and one of the biggest things we've noticed in the last decade, certainly exacerbated by the pandemic, but we saw it happening pre-pandemic, is the more transient nature of the healthcare workforce. I mean, it used to be you went to work in a community like Dr. Holmes, and you just stayed there your whole career. And we certainly have members of our medical staff who do that. But more and more, there are people, I want to be here for a while, and then there's another opportunity, or, a spouse or a partner is, has an opportunity somewhere else.
And of course, traveling nurses come right to mind.
Absolutely.
In fact, your nursing staff, what percentage? Are we talking a significant percentage that are traveling nurses?
I couldn't tell you the percentage off the top of my mind, but I know that we spend millions of dollars, not in traveling nurses, but the premium that traveling nurses have above, the wage of a staff nurse. So it's our number one thing. I mean, we're very fortunate. I think most of the traveling nurses we get are wonderful people, great clinicians, and helping us out when we're in a jam.
And you'd be in touch without traveling nurses. You'd be in pretty. I mean, you just don't have enough.
We wouldn't be able to serve the community to a fraction of what we do today.
When did that start happening? Have traveling nurses been around for quite a while?
Yeah, they've been around for a long time, as long as I can remember, for sure. But it was always, I'll say dramatically less than it is today. If you had one or two travelers in-house, that wasn't necessarily uncommon, but it was for a short period of time. It was, for a key transition or an unexpected loss of a staff member, and it was a short period of time.
Yeah.
We have 30 plus travelers, and we've had that at a sustained level for a number of years now.
Really?
And there's a reason for that. There's an allure. I think that younger staff members want to travel.
Yeah, no, it
see
sounds like
different places.
great. If that's what you're into, it sounds pretty cool.
It is pretty neat for a while. I think what I have seen over the years is that not being home gets old.
Yeah.
You can certainly make good money for a little bit, and don't be fooled. What we pay for that doesn't all go to the nurse. A lot of it goes to the company.
Yeah.
So there's an allure for it for sure, but I think you don't have the emotional connection to a community the way you do if you live in a community. You can't necessarily grow and develop your career like you can when you're working in your own community.
How long traveling nurses? If they have a traveling nurse comes to NMC? How long does he or she have to be? Is it a set amount of time that they?
It can vary, but I would say that it certainly can vary. I would say the standard assignment is a 13-week assignment.
13-week.
Yeah.
And most of them will stay longer than that, or just not necessarily?
No, some will do that and go, and go to the next spot. Some like to do it seasonally, and some will sign on for successive assignments. We try really hard and have kind of an internal rule not to let anybody work for us in a travel assignment more than a year.
Oh, really? Yeah. Interesting.
Well, we don't. I mean, our top priority is to value, support, and respect our full-time staff. Sure. And if you can be a traveling nurse for an extended period of time, there's no motivation to be part of our full-time staff. Right. So, we basically tell someone either between 9 months to a year, like, okay, you're either going to become part of our staff or you're not. And if you're not, you're going to have to go somewhere else.
Is Vermont doing better? Any hopeful signs of trying to get more nurses being educated in Vermont? Seems like I've seen a few stories about that, but...
I think the pipeline is doing a lot better.
Yeah.
We've certainly seen substantial growth in the education system for nurses.
Yeah.
There's been some wonderful creative thinking about how we educate nurses and when. Yeah. We're moving a lot farther upstream to talk to young folks about working in the healthcare field and not only becoming a nurse, but becoming a rad tech, becoming a coder, becoming a biller, working in IT. I mean, we used to go and talk to high schools, and now we're talking to middle school and elementary school in some cases to start have them think about those careers now. I think Vermont, like they always do, works really creative. I mean, the benefit of being a small state is we all know each other, and so breaking down those barriers to get to creative thinking is a lot easier when you know who you're working with. Right. So, and I think the professions themselves. I think nurses are talking a lot about what it's like to become a nurse. We talk about the young folks, but nurses are also doing a great job, as are hospitals and other healthcare institutions, in talking to older adults about a second career. Yeah. We have a lot of folks who are entering nursing or another healthcare profession, like the ones I mentioned before, as a second career. And I think that's great. Yeah,
I've got a very good friend at NMC who's a nurse who flipped careers. I'm so impressed when he did that maybe 10 plus years ago. But no, that's very impressive to me when someone does that. Recruiting, doctor, how are you doing on the recruiting front? Are you always looking for more doctors? Is NMC in pretty good shape now? Or? I
would say NMC we are recruiting, for at least 2 new doctors, but we've recruited more than 12 doctors in advanced practice, so nurse practitioners or PAs, in the last 12 to 18 months. NMC is really a recruiting mecca. I mean, we leverage where we are. We leverage the Vermont brand and being close to Chittenden County without having to live in the busyness of Chittenden County.
Not to mention Montreal being close.
Montreal being close, absolutely. Yeah. There's that's been a big winner for us, for sure. And so we've recruited a lot of new providers. We're really excited about that. Right now what we're recruiting for an OBGYN to join that team, and we're recruiting for an orthopedic surgeon. And the OBGYN is to fill a known hole. The orthopedic surgeon is in preparation for one of our doctors who's planning on retiring.
Interesting. So that's gone pretty well. You're in pretty good shape staff-wise?
Outside of those two areas, absolutely. Yeah, I think we're very fortunate. I think not only folks who want to be in Vermont, and that's one of the great recruiting pleasures is, people who come here want to be here. They have either went to, summered here or wintered here. When they were kids, they did their training here. They have family close by. So
is that right? So there's often some connection when you
absolutely having a family connection or a previous life experience that's in Vermont is a key metric for being successful in recruitment.
Other hospitals, you've got a good handle on other hospitals in Vermont. Are some hospitals just having a much tougher time recruiting? I mean, it sounds like. What are we talking about? 14 community hospitals in
14
Vermont,
community hospitals in the state. Yes. I think we're probably one of the most fortunate. I don't think that we're leaps and bounds above the other hospitals. And it all depends. If I were a medical staff provider, being in the Northwestern area would certainly be an attraction to me because my children live close by. But I went to school and spent a ton of time when I was younger in the Northeast Kingdom. So that would be an attraction to me. Like I said, it's all that connection and finding the right person at the right time with the right value set, right? And I mean that by saying, if you're recruiting someone to NVRH or North Country, it's somebody who has to really love what the Northeast Kingdom is, right? If you're recruiting someone to Mount Ascutney or someone in the Upper Valley who wants to be near the hustle and bustle of the Upper Valley or Chittenden County, right? Dartmouth Hitchcock. That's probably not the same kind of person that wants to be, say, in Bennington or in Rutland or in the Northeast Kingdom. So it all depends on what the person you're recruiting, what they're looking for. If you're just hiring a heartbeat who says, I don't care where I work, I just want a job, that will fill a short-term fix, but long-term usually doesn't always create the longevity that we're looking for.
Yeah. So what's in store change-wise for Northwestern Medical Center for the year we've just started, 2025? Any big stuff going on, major stuff?
Absolutely. I think, the Green Mountain Care Board dug a little bit of a hole in our budget, so we're trying to figure out how to resolve that.
And how much of a hole, what was your budget, what were you looking to increase by?
We asked for a 7% rate increase.
Was that typical in the state? Was that pretty? That
was a little bit above the average.
Okay.
But I think to keep in mind and to put in perspective, Northwestern Medical Center is the lowest cost hospital in the state.
Really? Lowest cost hospital?
Yeah, we have the lowest outpatient rates, and we have the second lowest inpatient rates. We have the lowest expense growth in the last 5 years. Really? Our expenses have only grown 17.5%. So that's the lowest by far of any hospitals in Vermont. We've asked for, since the inception of the Green Mountain Care Board, we've asked for the least amount of rate increases over that 13, 14-year period. So we are the lowest cost hospital in the state by far. And so, for every 1% that we ask for, that yields a lot different than 1% for any other hospital.
Interesting. But that didn't impress Green Mountain Care Board as much.
No, the Green Mountain Care Board treated everybody. If you asked for more than 3.4%, it didn't matter. You didn't get it. You didn't get more than 3.4%.
Really? And that's what you got. That's what everybody got, or
no? There were 3 or 4 hospitals that asked for less than that, and they got what they asked for when they asked for less. But kind of treating people unilaterally without understanding the conditions. And the situation.
That just sounds very strange.
Yeah, it's kind of a blunt instrument and kind of highlights that either they don't fully understand the circumstances, or that they don't care. Either way, not the way I would regulate or advocate for the people of Vermont, let alone the Northwestern.
So you got about half of what you were looking for.
Yeah, and that created, that and some other conditions created about a $3 million budget hole for us.
Is that where the dialysis?
No, that's even,
that's a separate.
I mean, the dialysis issue, that's a UVM issue.
Okay.
We're advocating for the patients in our community because I think it's really important that those patients don't travel.
And what's the story with that? You still have the unit right now, but the future is...
UVM is continuing to run the unit. They're continuing to work with the department at the state and the Green Mountain Care Board. We are at the table to advocate for our patients, but I'll be honest.
It's a UVM issue.
Yeah. I mean, the first solution that everybody seems to like is just turn it over to the community hospitals. I don't like that for two reasons. One, we don't have the experience. We don't have the expertise.
So you couldn't, if UVM said, hey, they're not letting us do this, so it's all yours. It's not like you folks could just take it over tomorrow.
The only way we could take it over is if we leased all of those services from UVM. And if we did that, you're not addressing what the Green Mountain Care Board was trying to do, which is the cost. You're just passing the cost on to a different hospital. I've already got a budget hole. I can't make that hole deeper. I'm trying to climb out of the hole, not make it, $500,000 to $1 million deeper.
So not clear at this point about the future of that unit then, or?
No, it's not. All that everybody seems to agree so far is that people shouldn't travel. Making people in Franklin and Grand Isle counties go to Malone, New York, which is the only place that has capacity, the closest place that has capacity.
So it's not like going to UVM, going to Malone, New York.
No, Burlington has no capacity.
Oh, is that right?
None whatsoever. Wow. They could not take these patients on.
So Malone, New York?
Malone, New York.
Does that operate every day, or is it every other day? The dialysis unit at NMC, is that
in St. Albans? Yes, it operates every day.
Every day.
Yep.
Wow.
So the answer seems to be, and quite frankly, there aren't very many hospitals running dialysis anymore in this country.
Really?
The overwhelming majority of dialysis units across the country are run by 3 for-profit organizations. U.S. Renal, DaVita, and a company called Fresenius.
And I can only assume none of whom are in Vermont.
No, I believe it's Fresenius runs a center in St. Johnsbury.
Oh, really?
Dartmouth just sold their program a year or two ago to Fresenius, and over in New York, UVM actually partners with U.S. Renal.
Oh, really? Have any of those folks made any noise about any chance one of those folks could set up shop in St. Albans?
Absolutely.
Oh, is that
absolutely.
Right?
I think the prevailing wisdom is, why aren't we looking at this company or any one of these companies and letting them bid? And if they decide to do that, they should probably, from a scale perspective, will probably want to bid on, all of the units for UVM. And I think that scares people for a variety of reasons, right? If I were a staff member working in that unit, maybe I've worked for UVM for a long time, and maybe I don't want to work for a for-profit organization or anybody else for that matter. I understand that. I have all the empathy in the world for the uncertainty that would create for their staff. But that's not the position that we're in, right? I mean, the Green Mountain Care Board leveled an order against UVM. UVM is responding to it in a way that they think is the most responsible thing for them to do, given all of the pressures on them. And this is where we are. And I think it's okay to have this conversation, especially when you look at and say, very few hospitals across the country run dialysis units. So why are we doing it, right? And or why is UVM doing it? So I think it's okay to have that conversation, understanding it's going to make a lot of people uncomfortable. And change is hard and different, and I totally understand that, and I understand it means a lot of change potentially for the staff and the providers, and uncertainty for patients. However, I think we can insist on the idea that the clinics stay where they are, so people don't have to travel any more than they are already. And I think that is single-handedly the most important part of it. No one said anything about the quality of these facilities. I mean, they do this across the country. If they've been that successful, the natural assumption would be they're good.
Quality's pretty good.
And it's it's like we were saying earlier with FQHCs. It's all they do. They don't do anything else besides these services. So, if that's all they do and they do it across the country.
So that seems to be the future of this particular thing.
And they the assumption is that they can do it at the cost or less than it's being done now, because they can take advantage of their purchasing by volume. In many cases, some of them are what's called vertically integrated organizations, so they manufacture their own supplies.
Right.
So they're not paying for the middlemen in the manufacturing process for what is arguably the most expensive part.
Are there other aspects of healthcare that are going kind of privatization? Like dialysis, anything else?
That's a big question. It depends on where you are in the country. It depends on volume. Sometimes that's good. Sometimes that's bad.
Yeah.
So that's a big question. We'd probably take an hour just talking about that.
Yeah. Back to your budget. So you got about half of what you're looking for from Green Mountain Care Board. So how is that I assume, negatively impacted you by not getting?
We wanted a 1% operating margin, which is a conservative but reasonable operating margin for a nonprofit healthcare provider. Industry standard is about 3, but we recognize that that's probably not a reasonable place to be in the Vermont market. So we were targeting for 1, and now we're looking at upwards of, it creates a $3 million gap. So that could be $1 million to $2 million in losses, depending upon the volume of our patients. I mean, part of what's so hard is, this isn't PepsiCo. We can't forecast with great certainty like they can what sales are going to be. Our sales are when people get sick, and some of that is predictable. You can kind of say, we see somewhere between 80 and 100 patients in our emergency department every day on average.
Is that right? 80 to 100?
It's pretty predictable.
Wow.
And there are other areas where it's not. And particularly when the Green Mountain Care Board has just done something that's forcing the university to lower their footprint, well, those folks have got to go somewhere. And if the policy decision at the state level is for the university to have a smaller footprint, that means we have to have a larger footprint. So, it's hard for us to say if we do more volume in the 4 or 5 areas that create an operating margin for us, we might be able to get to break even, or we might not lose as much. If we do more volume in areas that we actually lose money, we could be digging a hole deeper.
How many inpatients typically does NMC get?
On average, we have about 28 inpatients.
How many beds? What's your capacity for 40 or something?
We have 38 beds on our inpatient unit. Then we have an OB and pediatric unit that has another 10 beds. So the 28 is on our inpatient unit. That's ICU, step down in our medical surgical unit. This time of year, it starts to tick up. We'll regularly hit the 34 to 38, which we have 34 rooms. So that's one level of full.
And nice rooms. I think you did a great job on your room, the new rooms, which...
NMC is a beautiful facility. I think one of the things that we can be most proud of is we have a first-class facility. We've been able to continue to invest in our facility over the years, and it shows. So we'll run it, we'll run higher in the wintertime as respiratory season is here, and some others. And then on the shoulder seasons, the spring and the fall, we tend to lighten up a little bit. So, there's seasonality to what we do.
So you have enough, it sounds like you have enough inpatient bed. You don't need to have more beds?
No. On average. I mean, it's a complicated question, right?
Sure.
Talk to me in a couple of weeks and we could be full.
Once in a while, do you
that's a
have to
problem.
ship folks to Berlin? I mean, do you get full once in a while and have to ship folks, patients someplace else, or is that
Yes,
pretty,
I mean we
not too often?
ship patients to Burlington
Obviously,
for a
for some-
variety of reasons.
Sure.
If they're sicker,
Sure.
we're shipping them there probably every day.
Sure.
But when we get to capacity, we try not to. When we get to capacity,
Yeah.
what we do is we may hold folks in the emergency department a little bit longer. We kind of reach out to. The other side is, there's we're talking about the inbound, but the outbound, there's a lot of problems getting folks out of the hospital when they need to be out of the hospital.
And when you say problem, people who are just don't want to leave, or just uncomfortable, saying, "Hey, I need to stay here longer," or
all of the above.
Yeah.
There's they don't need a hospital anymore, but they maybe need a long-term care facility or a memory facility or some other type of facility, and those folks don't have access. So we're waiting for a bed to transfer them to. There is absolutely folks who say, I'm not ready to go. And we try not to say, too bad, so sad. We try to work with them and get them emotionally ready, work with the family to get them emotionally ready to take care of their loved one or to take care of themselves if they're going home. And it's a rare occasion, but every once in a while, people will say, I'm not going. And, we have to remind them that, number one, it's not necessarily your choice.
Yeah.
Our requirement is to provide a safe discharge. And once we can provide a safe discharge, then we're allowed legally to discharge somebody.
Yeah.
But number two, every moment that they spend in a bed that they don't need, it's taking a bed from someone who does need it.
Yeah.
And it's not like we can just send those folks to another hospital. One, that wouldn't be fair. They're in a different community. But number two, they don't have beds either.
Yeah. I assume some of your patients are folks you get no money from. I mean, if someone shows up at Northwestern Medical Center in dire straits, Peter, do you have to deal with anybody who shows up? Is there some free care here, or folks who just what do you do?
Certainly. First and foremost, we take care of everybody who comes through our doors, regardless of their ability to pay.
That's what I thought.
That's not only part of our mission, it's federal and state law.
That's a mission, so that's everybody.
Right.
Okay.
So everybody gets taken care of to some level, regardless of their ability to pay. We absolutely have folks who don't have insurance.
Right.
Northwestern Medical Center, Vermont has one of the most generous financial assistance policies in the country,
Really?
And Northwestern Medical Center was leading the way. So we provide a sliding scale up to 400% of the federal poverty level, and we were one of the first hospitals to implement that policy, which was closely followed by the state making it law.
Interesting. What percentage of people you deal with who don't have any insurance? Have you got
It's pretty small, and I say that it's
small.
pretty small as the number of people that come through the door that don't have insurance doesn't necessarily match the number of people who leave without insurance. A lot of what our care managers and our financial assistance folks do is help folks say, hey, you qualify for this program.
Oh, really?
And that's always our first priority to say, if someone qualifies for a program, we want to help them get on the program. Not simply because we would get paid that way, although that's certainly a benefit, but we want them to have access to, we know insurance becomes a barrier to care. So people will go without care if they don't have insurance. I mean, there's all kinds of really good research that shows if you have access to insurance of any kind, you're more likely to engage in care earlier in a process, which means you're more likely to get preventive care instead of urgent care.
Interesting.
So we do that, but somewhere in the 2 to 4% is our uninsured kind of out of pocket, and that's shrunk over the years. Certainly, what's affectionately the ACA, or what's affectionately called Obamacare, helped bring that number dramatically down with insurance exchanges and things like that.
Interesting. Down to about one minute. Northwestern Medical Center. I mean, it sounds like all kinds of challenges, but you feel like local hospitals in pretty good shape?
I think we're certainly have challenges to overcome. I think the community should be very proud of the incredible facility and the people that come to work to take care of them every day. I mean, I'm just moved every day at how wonderful the staff is and what a good job they do. I get my own care at NMC. For everything that I can get at NMC, I do get at NMC. And I think that speaks volumes, right? I think nobody should have any reason, nobody should feel like they can't come, that it's, we provide safe, high quality care. It's the lowest cost, so you're simply going to pay less if you come to NMC, and it's something the community should be really proud of.
On that positive note, we'll call it a day. Peter Wright, Chief Executive Officer of Northwestern Medical Center. Thanks a lot for the time. Really appreciate it.
Thank you for the opportunity. It was a lot of fun.
Thanks. Thanks to Alan Cunningham, my producer. Thanks for watching us on Northwest Access TV. I'm Richard Cowperthwait. See you next time.